Hello students, I'm the OGGuru Dr. Punit Bhojani here with a single point agenda to make OBGY your most favorite subject, most scoring subject. A very important video coming up, stay right till the very end. Top 6 most frequently repeated gynecology topics with MCQ discussion for the upcoming NEET PG 2026. We're going to tell you the topics. We are surely going to come with MCQ discussion. Stay right till the very end. It's going to be a very important video, and get in touch with me on phone and WhatsApp on this number for your timetable and guidance. Download the OGGuru app and 5 months NEET PG combo. My dear students, OBGY will become your most favorite subject, most scoring subject is my guarantee. Just in 1550, you are going to get the detailed theory lectures, rapid revision MCQ, beautiful handwritten notes, and of course my mentorship and personalized timetable and guidance. So download the OGGuru app and get in touch with me. More about this later on. Let us begin. The topic I will tell you later. First, a clinical case base. Please understand OBGY and NEET PG. Overall, NEET PG has become absolutely crystal clear concepts, whose concepts are clear because concept based questions are coming. So let us look at the first MCQ. What is it? A 27-year-old patient, married since 3 years. Start thinking. She is obese. Okay. Acne, hirsutism. What is it telling you? Irregular periods. So start thinking in terms of diagnosis. LH level 15, FSH 5. So from this, can you tell me what is the diagnosis? Yes, sir. The diagnosis is PCOS. Why for PCOS? Because, sir, obesity points to PCOS. Yes. Acne, hirsutism points to hyperandrogenism. Irregular periods tells me something that, sir, ovulation is a problem. And just by the way, all of you know the ratio is also altered. What is the normal ratio? Please comment in the chat box. What is the normal ratio of FSH-LH? Please comment in the chat box. Please also comment in the chat box what criteria do I use? What criteria do we use to make the diagnosis of PCOS? Please comment that. And then यहाँ पे हम देखेंगे कि the ratio is 1:3, which is also suggestive. However, the ratio is not a part of the criteria, but yes, ratio is altered. 1:3 is suggestive of also PCOS. Which day? FSH-LH blood test has to be done on which day of the menstrual cycle? Please also comment in the chat box. I'm going to give you answer over there. So I repeat, आप मुझे 3 things बताओगे. You'll tell me which criteria we use for diagnosis of PCOS. What is the normal ratio? When to do the blood test? Very important MCQ. Now, आगे patient is, so what happens? Student directly read this and they say, sir, OC pills with cyproteron. Wrong. Why wrong? Because OC pills, yes, you give her for treatment of acne and hirsutism, but wrong. Why wrong? Because, sir, patient is trying to conceive for the last 2 years. So here, what is the most appropriate treatment for her condition? So, sir, married since 3 years and trying to conceive since 2 years. So this is PCOS. I've already told you based on our hyperandrogenism ke signs and obesity and the ratio, and that is the first and the very important topic. Short questions come on this topic, and that is PCOS. Now, how do you proceed further? Now, please tell me one word answer. Remember, the treatment of PCOS always depends on what the patient wants. So here the patient is trying to conceive. She is trying to conceive since 2 years. So there is infertility. So when the patient of PCOS has infertility and or is planning pregnancy, patient says, doctor, I want pregnancy, plan pregnancy or infertility. One word answer. Tell me why there is infertility. Yes, sir, the infertility is because of an ovulation. So therefore, can you tell me when the patient is having an ovulation, what are we supposed to do to make her fertile or make her pregnant? And we don't have to do, what do we give her? Yes, we have to go for ovulation induction. Is this understood? And therefore many students directly will mark clomiphene. Again wrong. Please understand this that clomiphene. So OC pills we don't need to give her, because OC pills when you give, I will tell you, here she is planning pregnancy. Jo patient pregnancy plan kar raha hai, usko I can't give birth control pills. Is it clear? No role. So again, clomiphene, my dear student, was the drug of choice. CC was. Please write down was. was the drug of choice for ovulation induction. Was. Now what it is? Yes, sir. Please keep in mind, after 2018, there was a very big study, and it has shown that letrozole is giving better success, better result, and therefore letrozole is now, please write down, now the first drug of choice for ovulation induction in PCOS. Clomiphene is not that it is banned or something, or clomiphene is not your second choice. First choice is always letrozole. So student यहाँ पे भी again फिर क्या mark कर देगा directly? Letrozole. Again wrong. So see how all three what you were thinking is wrong. Why? I'll tell you the answer. So first you thought, okay sir, acne hirsutism hai, let me mark ossipils. That I told you wrong. Why? Because she's planning pregnancy. Then you said, okay sir, planning pregnancy, clomiphene, again wrong, because clomiphene was the drug of choice. Letrozole is now the first drug of choice. Okay, but then why letrozole is not the answer? Picture abhi baki hai. Okay. Now, please understand this. Okay. So, whenever the patient is having PCOS, infertility is because of anovulation, yes, I go for letrozole. Absolutely correct. Letrozole. But, can you tell me the hallmark of PCOS is something insulin resistance? And therefore, here also we know that patient is obese. And can you tell me what will help in insulin resistance? And therefore, remember my dear student, if they ask you initially, always, yes, all patients, lifestyle modification, lifestyle changes, lifestyle modifications, very important. Uske saath diet, exercise, weight loss, all this is very, very important. And what drug can I give to tackle insulin resistance? Metformin. So along with this ovulation induction, M stands for metformin. Metformin should also be given to the patient. And my dear student, it's a partnership. Any patient who is infertile, I need to evaluate the male partner also, isn't it? Patient is trying to conceive since 2 years. So male partner, will I evaluate or not? Of course you will evaluate. And therefore, my dear student, option D is the answer. Okay, so letrozole for the lady, metformin to help her in weight loss and target obesity and insulin resistance, and of course evaluate the male partner. And therefore D is much better than C. C is not completely wrong, but C is partially only correct. Okay, I'm saying if D is not in the option, then C is the answer. D is the answer. Is it crystal clear? No confusion. So D is, so this is how they'll confuse you, or MCQ is going to come in the exam. So D is much better than C as an answer. D is better than C, and therefore D is the answer. Okay, so letrozole for ovulation induction, metformin to help her weight loss, and metformin also improves the success of letrozole and target insulin resistance. And of course, I need to evaluate the male partner by doing his semen analysis also. That's a very well complete, rounded answer, perfect answer. As a consultant, they want you to think hashtag crystal clear concept. OG in the chat box. Please comment OG in the chat box if you are loving this. Chokotali. Is it clear? And also please comment what is the most common side effect of metformin. Metformin ka most common side effect kya hai? Please comment. Okay. And now, so second kind of patient, another patient who says, doctor, I am not planning pregnancy. I don't want babies right now. Then what do you do for her? And suppose she is having irregular periods. What do you tell her? Suppose she is not getting her periods. She has got acne, hirsutism, and she is not getting her periods. She has got acne, she has got hirsutism, and she is having irregular periods. Okay, that's the second category of patient. Now, what do you tell her? What do you tell her? Okay, do I treat her or not to treat? Very good. Why to treat? No problem. What do you tell her? Okay, whenever you want to become pregnant, you come to me. I'll make you pregnant. I will make you pregnant means I will not make you pregnant. I will give you this ovulation induction and then you can become pregnant. So, abhi kyun treatment dena hai? Yes, sir, she also may require treatment for acne, hirsutism and this irregular periods. It is because of estrogen excess. If you don't treat her, the amenorrhea which the PCOS patients have, is because of estrogen excessive estrogen. So if I don't treat her, I am exposing her to the long-term risk of endometrial hyperplasia, endometrial cancer. Okay, and therefore even the young patient of PCOS who is not married or even married but wants treatment for acne, hirsutism and irregular periods, what do we do? एक ही गोली, नाम में ही आंसर है. Nobody will teach you like this. Clap. PCO, just invert it, उल्टा कर दो OCP. PCO, OCP means what? Sir, polycystic ovary, oral contraceptive pills. And that is the answer. If they tell you that patient wants treatment for acne, hirsutism, irregular periods. And of course, to both of them, metformin can be added. Metformin can be given with ovulation induction and letrozole also. Metformin can be combined with ocipils also. Of course, diet, lifestyle modification is understood. Is it clear? So remember what the treatment wants. I give this one more. If here they said, okay, patient wants treatment for acne. Here they said, sir, patient is anxious to conceive, trying to conceive for last 2 years. She's married for 3 years and trying to conceive. That means I have to go for fertility. If they said patient wants treatment for only acne, hirsutism, then ocipils is very good. And cyproterone is a progesterone with anti-androgenic property. Cyproterone is an anti-androgenic property. Ocipils is very good for treatment of acne, hirsutism, irregular periods. Not in this case. So in this case, letrozole, metformin, evaluate the male partner because patient wants pregnancy. Here, patient wants to become pregnant. PCOS, planning pregnancy. That is the answer. Clap. Moving on to the second most important topic, hysterolaparoscopy. Very, very important. Always a question comes and students are totally confused. What is hysteroscope, laparoscope? I will there to guide you. Okay, clap. Now, all of the following can be diagnosed by laparoscopy except ABCD. Okay, now these students have a total confusion. Let me clear it for once and for all. Sir, in laparoscope, I put in a telescope through the anterior abdominal wall. Okay, and we can see from outside the uterus, the uterosacral ligament, the fallopian tubes, ovaries, pouch of Douglas, all that I can only see on laparoscopy. Hysteroscopy cannot see all these things. Why? Because sir, in hysteroscopy, so this is L, this is laparoscopy. I'll show you the picture also. In hysteroscopy, what do we do? So hysteroscopy, I tell all the students, is inside the classroom view. If all of us are in one classroom, I can see all of you. So hysteroscopy is putting in a telescope through the vagina, through the cervix to evaluate the cavity of the uterus. Very, very important. Hysteroscopy is to evaluate the cavity. Whether, sir, what all problems I will tell you. So laparoscope is a terrace view. When you go on the terrace of the building, from terrace of the building, you can see the cars and the road from outside. Now tell me yes or no. If you go on the terrace of the building, from there, can you see how many students are inside the classroom? No, never. So laparoscope cannot see the cavity or inside of the uterus. And vice versa, when you are inside the classroom, can you tell me who is standing on the terrace? No, never. So hysteroscope cannot see the outside. Laparoscope is going to tell you the outer view. Hysteroscope is going to tell you the inner view. Clap. Thoko tali. So in laparoscopy, sir, I can see the uterus from outside, I can see ovary, all that tube, ovary, all and pouch of Douglas and pelvis. So now bicornuate uterus, very good. Sir, if there are two horns, I can come to know by doing a laparoscopy. Very good. Those separate horns I can see by doing laparoscopy. Very good. That yes. Okay. Unicornuate uterus also yes. Sir, in unicorn, there's a single horn also, unicornuate, that also the laparoscope can see and find out. Very good. And of course, for endometriosis, laparoscopy is the investigation of choice. What all do I see in endometriosis? Yes, sir. Sir, we can see a chocolate cyst. We can see a chocolate cyst. Sir, we can see adhesions between the tube and the ovary. And what do we see in the pouch of Douglas? Yes sir, powder burnt, matchstick burnt spots we can see. And my dear students, हम क्या बोलते हैं? Fruit salad. Yes, blueberry, blue color nodule, red raspberry, red strawberry. All these things are the various findings in endometriosis. So sir, in endometriosis, everything is outside the uterus. And also tell me, laparoscopy is the best investigation for tubal patency. How laparoscopy? What dye will I use and what do you do? Laparoscopy is the gold standard or confirmatory also for tubal patency. What is that thing called? Laparoscopy what? And what dye is used? Please comment in the chat box. So also for bicornuate uterus, unicornuate uterus, endometriosis, tubal patency, all that is required laparoscopy. Why is the answer septate uterus? Because sir, septum is within the cavity. Yes, like this. So for septate uterus, for septum is projecting, septate uterus will require hysteroscopy. Similarly, sir, if it's an endometrial polyp or there are intrauterine adhesions, what is it called as? Please comment in the chat box. Okay, intrauterine adhesion is called what? All this will require hysteroscopy, not only for diagnosis, simultaneous treatment and management. All of you look on the board. With the hysteroscopy, I can cut the polyp. See this, polyp gone. Hysteroscopic polypectomy. I can cut the septum. Last year question, sir, hysteroscopic septal resection and hysteroscopic adhesiolysis. So sir, hysteroscopy is required to confirm the diagnosis of septum and also treat the septate uterus, requires hysteroscopy. So septate uterus is the answer. And what is the surgery? Sir, hysteroscopic. It is called septal resection. Okay, resection of the septum. Hysteroscopically you will go and you will do a septal resection or septoplasty or whatever. Okay, so septate uterus, sir, requires hysteroscopy. Laparoscopy cannot see. Now see this, all of you look over here. Yes, this is a laparoscopy view. You are seeing the uterus, you are seeing the fallopian tube, ovary, pelvis, pouch of Douglas, all that we are seeing. Now you only tell me from here, can I see what is inside the uterus and the cavity? No, never. Can I see, sir, the cavity, sir, the uterus? Uterus के अंदर there could be a fibroid or a polyp or there are adhesions or there is a septum. All that the laparoscope cannot see. The laparoscope will tell you only the outer surface of the uterus. समझ में आ गया? Clap, ठोको ताली. To see the cavity of the uterus, what will I require? Hysteroscopy. Hysteroscopy. Is this understood to all of you? तालियां बजती रहनी चाहिए. So very important topic. Short question coming. Next topic, amenorrhea, and in this primary amenorrhea. Short topic again every year coming. Primary amenorrhea definition has changed, and now please understand this. The new definition of primary amenorrhea is what? The 14 years and 16 years is now old. Kachra, dustbin, don't follow that. Many students are still following that. 14 and 16. No. Primary amenorrhea, the new definition, two numbers to be kept in mind, 13 years and 15 years. If there is no menses by the age of 13 years, but along with that, if there are no secondary sexual characters, SSC, secondary sexual characters means breast development, axillary pubic hair. So if there are no secondary sexual characters, then even at the age of 13 years, I can label the patient as primary amenorrhea. But if secondary sexual characters are present, okay, I repeat, SSC is not your SSC board. This is my short form, secondary sexual characters. That means breast development, axillary pubic hair. So if secondary sexual characters are present, then we can wait till 15 years. And if 15 years also, there is no menses. If there is no menses, 13 and 15. 15 years in presence of secondary sexual characters, that is primary amenorrhea. I am going to give you a mantra which lifelong you will not forget. Patient presents with primary amenorrhea. Okay. On examination, breast is well developed, fine. Absence of axillary pubic hair. Lump felt in the inguinal region. USG absent uterus. Short question coming. You'll remember me on the day of the exam. मंत्रा ये है माय डियर स्टूडेंट कि इफ इन द एग्जाम यू गेट अ कॉम्बो पैकेज विच एवरी ईयर यू विल गेट, क्या कॉम्बो पैकेज मिलेगा? कॉम्बो ऑफर, कॉम्बो पैक कि सर इफ देयर इज प्राइमरी अमेनोरिया along with it absent uterus, if you get this combo package, my dear students, only look at option 1 and option 2. Option 1, option 2 matlab only two possibilities, only two possibilities in whole of gynecology. Don't even look at option 3, option 4, whatever may be option 3, option 4. Okay, matlab any name, it could be any new syndrome you have never heard also, no problem. Only two options, either RMKH or Mullerian agenesis, rocket and schemaire Kushner-Hauser, or androgen insensitivity syndrome, complete androgen insensitivity syndrome. I repeat, primary amenorrhea, absent uterus, only these two are the possibilities. So let the third option, fourth option be anything. Kalman syndrome, Sheehan syndrome, XYZ syndrome, Sware syndrome, जो भी any other name, you don't have to bother. What are the two things you will keep in mind? Yes sir, here we have got primary amenorrhea, very good. We have got absent uterus, that's it. Turner syndrome, uterus is present, and Kalman syndrome also uterus is present. Please comment in the chat box what is Kalman syndrome. Kalman syndrome क्या है? तो हमको खाली देखना है ये दो. Okay, and what is the main thing? Yes sir, the main thing is, which is of course karyotyping. If I do, this is 46XX, and ये तो लड़की नहीं, ये तो लड़का है, 46XY, it's a boy. But most important, that's why doing the blood test. Again, one more MCQ bonus. But how are we supposed to look? Yes sir, please look at the axillary and pubic hair. Okay, even in females, the axillary and pubic hair is androgen dependent, and androgen is working over here. RMKH is absent uterus, normal ovary. So ovaries secrete testosterone, adrenal gland also secrete testosterone, and axillary and pubic hair will be well developed over here, and here axillary and pubic hair will be absent. That is the clincher, that is the clincher. Breast is well developed in both, so please don't get confused. Breast is well developed in both the cases, here also plus, here also plus, that's not a difference. Okay, so यहाँ पे absence of axillary and pubic hair, and therefore the answer is what? Yes sir, the answer is androgen insensitivity syndrome. Primary amenorrhea, absent uterus, absence of axillary pubic hair. And one more thing, what the lump felt in the inguinal area? Yes sir, sir, in RMKH the gonad present is ovary, and here the gonad present is testes. But because androgen cannot act, testes is lying in the inguinal area, undescended testes, and this lump felt in the inguinal area is the testes. Is this understood? Clap. So lot of extra information I have given you, and this topic again surely coming, ये है आपका androgen insensitivity. If here they say primary amenorrhea, absent uterus, well developed axillary and pubic hair, then your answer will become RMKH. Is this understood to all of you? Yes. So please understand this, कि primary amenorrhea, absent uterus, in RMKH axillary pubic hair will be well developed. यहाँ पे it is absent. And also comment in the chat box, what is Sware syndrome? What is Sware syndrome? Okay, and what is the karyotype? Okay, this is 46XY. What is Sware syndrome? How to differentiate from androgen insensitivity? What's only one difference? And what's the karyotype of Sware syndrome? I'll give you the answer in the chat box. Okay, very important. So primary amenorrhea, absent uterus, only these two topics keep in mind. You'll remember me on the day of the exam. Again, short topic, contraception, hot topic आता ही है. Patient para 1 living 1. Copper T inserted 2 years back. Copper T threads are not seen. When you do a per speculum exam, copper T threads are not seen. What do you do next always? Yes sir, whenever the uterus आपने copper T डाला है, you have put in a copper T, and now the copper T has a thread. If the threads are not seen, what could be the problem? Yes, sir. Either the threads have curled up. Threads have curled up and the copper T is inside the uterus only. हो सकता है. And second, what is the possibility? Yes, sir. Second possibility is, okay, sir, the copper T has also expelled out. Yes, it could be. Copper T has perforated. It is a gradual perforation. Copper T has migrated and copper T is inside the abdominal cavity. So you do ultrasonography. So remember, whenever there is a missing threads, basically threads are not seen. So whenever there are missing threads, you are supposed to do ultrasonography. Final MBBS student, gold medal level question. If ultrasonography is not available, which X-ray you will do and what's the specialty of that X-ray? Okay, you remember you have to do USG. Just by the way, they like to ask you such questions in Viva. If any final year student is seeing me, okay, if USG is not available, you will do X-ray, but how X-ray? X-ray with what? You have to put some instrument inside and do the X-ray and take epilateral view. That's a separate discussion. So USG shows copper T partly in the abdominal cavity. So sir, copper T, either the threads are curled up and copper T is inside only, or copper T is outside. Copper T is partly or completely in the abdominal cavity. Now what do you do? How many of you want to wait and watch? Never. Jail. We'll have to put you in jail. Why? Because copper T is in the abdominal cavity. If the copper T is inside the uterus, if it is inside, here you can wait and watch. Copper T अगर अंदर है, proper place में है, yes sir, we can wait and watch. But here when the copper T is outside, don't get fooled by the word partly. If it is partly or completely, if it is partly or completely in the abdominal cavity, never wait and watch. Anybody? Why? Why never wait and watch? Never, W. Never wait and watch. Why? Yes, sir. This copper T is a foreign body and this foreign body can cause adhesions, peritonitis, and adhesions and intestinal obstruction can take place because of this. In this obstruction, so never wait and watch. And right now only I told you, what can you do? Yes, sir. We can put in a laparoscopy and take the copper T out. So laparoscopy, and if the laparoscopy facility is not available, then even laparotomy will be required. No point doing a hysteroscopy. Samjha, because it is nothing inside the cavity. Cavity is okay. Is it clear? So hysteroscopy, sir, has got no role. You can never wait and watch. You never wait and watch when the copper T is in the abdominal cavity. Laparoscopy is the answer. If laparoscopy facility is not available, laparotomy karna padega. Laparotomy. So contraception, missing threads, very short, very hot topic. Short aane wala hai. Clap if you feel happy. So laparoscopy is the answer. Okay, moving on to a next topic, abnormal uterine bleeding. Again, very important. Okay, what is the topic? 48-year-old, para 3 living 3 patient. Very good. Complains of menorrhea since last 6 months. So she is 3 babies, family complete. TSH normal, BP thoda sa high, USG 1 cm fibroid. What is the next management? Majority students, I know you will say, sir, 48-year-old, family complete, menorrhagia, another word, heavy menstrual bleeding, HMB, for last 6 months. Many of you will say hysterectomy. Yes, sir, na rahega baas, na bajegi basuri. Yes or no? Wrong. Why wrong? Why wrong? Never directly do hysterectomy. Why? Why never directly do hysterectomy? Why? I'll tell you. मैं हूं ना. Then some student will say, sir, 1.5 centimeter fibroid. So they will say myomectomy. Again wrong. Clean bold. Dandigul. So why not? Okay. So why not hysterectomy directly? Why? Never directly hysterectomy. Okay. Never directly hysterectomy. Why? Because sir, this is 48 years old. She is perimenopause. And whenever a patient is perimenopause, 40-45 plus with heavy menstrual bleeding, what are we supposed to do? Now please understand this. here this 1.5 centimeter anterior wall subserosal fibroid is not, this is just a extra time pass information to confuse you. It is not the cause. Okay, it's not the cause of this heavy menstrual bleeding. Very important take home message. Why? Okay, sir, if this is the uterus and patient has 1.5 chin to, patient has a chin to 1.5 centimeter subserosal fibroid. This fibroid can never cause menorrhagia, can never cause heavy menstrual bleeding. Clap if you have learned something new. So here, sir, then what is the cause for menorrhagia? Yes, sir, something in the lining of the uterus could be the cause. Okay, and therefore, whether this line is given or not, whether 1.5 centimeter fibroid given or not given does not matter. The dictum is that any patient who is perimenopausal with heavy menstrual bleeding, you need to rule out, yes, I need to rule out endometrial hyperplasia and endometrial cancer first. Is this understood to all of you? Thoko tali. And therefore remember the rule, HPE is mandatory. मैंडेटरी का मतलब क्या है? HPE is compulsory. So any patient who is perimenopausal with HMB, histopathology मतलब एक टुकड़ा लाइनिंग का, I will do DNC. You will do a DNC and send that material for histopath, and histopath has to rule out endometrial hyperplasia, endometrial cancer first. Why? Because then only you can decide if it's a hyperplasia, what kind of hysterectomy you may want to do. If it's cancer, then hysterectomy is different. So I'm not saying don't do hysterectomy, but never directly do hysterectomy. Why? Because if directly you do hysterectomy and then the report is cancer, it's an inadequate surgery because you will remove only uterus and cervix. If it's cancer, uterus, cervix, fallopian tube, ovary, lymph nodes, radical hysterectomy has to be done. Yes or no? So जैसे आप होटल में सादा डोसा, मसाला डोसा, similarly सादा hysterectomy, radical hysterectomy, which hysterectomy to be done? Simple hysterectomy or radical? So myomectomy not required because this fibroid is not the cause for menorrhagia. No point doing myomectomy. It's a chin to 1.5 centimeter. Similarly, never directly give progesterone. Yes, first you rule out hyperplasia and cancer first, and then suppose it is hyperplasia and cancer, then hyperplasia, simple hysterectomy, better. Cancer, of course, radical hysterectomy. And suppose there is no hyperplasia or cancer, then yes, you can try progesterone therapy also, no problem. If it's not cancer, you can go for LNG, IUD, Mirena. So first you have to do histopathology, and then depending on the histopathology report, you will decide whether you want to conserve the uterus by giving some progesterone therapy or LNG intrauterine device, what is it called as Mirena, or you want to really do hysterectomy. All that is later on. It is not the question right now. The question over here is, remember, okay sir, whenever there is a perimenopausal patient who is having heavy menstrual bleeding, important is perimenopausal age group. क्या है? एक टुकड़ा लाइनिंग का. हिस्टोपैथोलॉजिकल एग्जामिनेशन ऑफ द एंडोमेट्रियम मैंडेटरी. हाउ कैन आई डू दिस? सर, वी कैन आइदर डू अ DNC or we can do a endometrial biopsy, or the best is we can do a hysteroscopy. Okay, hysteroscopy plus take the biopsy. You can see the cavity inside and then take the biopsy. Whatever you do, first do HPE, rule out hyperplasia and cancer first, because hyperplasia and cancer can only be ruled out on histopath. समझ में आ गया? So here 48-year-old DNC or endometrial biopsy, basically histopathological examination is the answer. Clap. And never directly do hysterectomy. Common mistake maximum students will make. Next, very important short topic. Again, the question comes oncology, and here you need to know what? Tandem radiotherapy, virgin MCQ. Many students directly clean mold. What is this tandem? कभी सुना ही नहीं है. Tandem radiotherapy. What is it? Yes. So remember, my dear student, for cervical cancer, CA cervix, when it is inoperable, 1A to 1B, 2A, till 2A we can do a surgery. When the cervical cancer is stages 2B, 2B, 3 and 4, 3A, 3B, 3A, 3B and stage 4 cervical cancer, these stages, then it becomes inoperable and then we go for radiotherapy. Now in this radiotherapy, understand this, so it is radiotherapy. For which stages of cervical cancer? Stages 2B, 3 and 4. Now this radiotherapy we give, उसमें होता है two types. One is teletherapy, from far we give, and one is brachytherapy. So radiotherapy could be teletherapy from external beam radiation, and it could also be a brachytherapy. Brachytherapy means we are going close to the organ and giving radiation. Okay, and by the way, just extra information, cisplatin is also given before radiation. Cisplatin is given first and then radiotherapy is done. So nowadays the word uses CTRT. CTRT is better, concurrent chemoradiation. Okay, so chemoradiation is a better answer. Okay, so CA cervix you treat with CTRT, which is called as concurrent chemoradiation or chemoradiation, and cisplatin is given first for stages 2B, 3, 4, and then you give radiotherapy. That's not the answer. So just to tell you that CTRT is better. So CTRT is better than only RT because cisplatin is a radiosensitizer. But now when I want to do this brachytherapy, what is done? Tandem. Tandem is what? So tandem is like a rod. So this is the uterus and there is something called as tandem and ovoid. Ovoid. If they tell you ovoid also, ovoid radiotherapy. So tandem and ovoids. So tandem is a rod. Tandem is a rod. The rod is put inside the uterus and the cervix. And ovoid are oval shaped spheres. Okay. So this assembly is called tandem and ovoid. Clap if you have learned something new. So it looks like this. It looks like what? Okay, it looks like this. This is a rod. This is a rod which is called as tandem, and then there are two balls like structure called as ovoid. And what is done is this is inserted inside the uterus through the cervix, and then it is charged with the radioisotopes. So that radioisotopes will then release and give radiotherapy for cervical cancer. So when you give brachytherapy, which is a part of your radiotherapy for cervical cancer, this tandem is a rod which is the device used. What is this device called as? Yes sir, tandem plus ovoid. It is oval shape. So tandem plus ovoid radiotherapy is a radio for cervical cancer. Ovarian cancer you have to give chemotherapy. Endometrial choriocarcinoma, again chemotherapy. Endometrial cancer is radiotherapy, but we don't give this. Okay, so tandem and ovoid is for cervical cancer. Which stages? Yes sir, stages 2B, 3 and 4. Is this crystal clear to all of you? Please comment in the chat box cervical cancer. What is the most common etiology? Which are the viruses responsible for causing it? Cervical cancer, please let me know. And what is the treatment preferred in stages early stage? In early stages, stage 1 and 2, what do we manage cervical cancer with? How do you management of cervical cancer? Stages 1A, 1A, 2, 1B and 2A, what do you do? For 2B onwards, I have told you, stages 2B, 3 and 4, we give CTRT. Is this understood to all of you? And my dear students, OBGY is a single most important subject. 20 to 22 MCQs every year are going to come in OBGY, and you can check. Every student has told me, okay, sir, all 22 questions in my NEET PG were from your lectures. Beautiful notes. You can see completely colored, integrated. I myself have read the notes with all the students. Every student has told me, okay, sir, once we have listened to your videos, we can revise the entire notes in 2.5 hours time. My dear student, it's a make or a break subject. I can assure you, if with your current knowledge, you are getting 10, 11, 12 MCQs correct in OBGY. After my lectures, your score is going to jump up to 18, 19, 20. All my students get 20 on 20 in OBGY. 8 MCQs more, 32 marks. 32 marks is the difference between rank of 4,000 and 40,000, or rank of 10,000 and 1 lakh, or a rank of 1,000 and 20,000. Minimum 8 to 10 MCQs extra correct, 30 to 40 marks more you're going to get when you enroll in this 5 months NEET PG combo of masterclass and rapid revision. Is my guarantee. OBGY will become your most scoring subject, most favorite subject. If this 35-40 minutes video has benefited you, all my students get 20 on 20 in OBGY, and it is the single most important subject. Download the OGGuru app and just use this coupon, and only in 1,500 rupees your life is going to change. You will be laughing in the lectures, and I'm personally available for all doubt and mentorship. There's everything: theory, lecture, MCQ discussion, quizzes are there. You'll attempt the quiz, beautiful handwritten notes. You can read the testimonials yourself, sir. OBGY, Bilkul Makhan, everything from your lectures. Only 2 hours to revise OBGY, all questions from your book and notes. Extremely happy, sir. Questions came the way exactly as you taught, and OBGY became the most helpful lecture. So same thing will happen with you, my dear student. When you walk out of the NEET PG examination, you will message me and call me and tell me, thank you, sir. Among all 19 subjects, my best performance is in OBGY. And share this video with all your friends and colleagues. Do not forget to follow me on Insta, and please subscribe to the YouTube channel. The PDF of this material will be available on Telegram also. And as I said, this is the first part of the series. I have given you top 6 in Gynac, and also very soon I'm also going to come out with top 6 obstetric topics. Top 6 topics in obstetrics also, 6 most important topics in obstetrics also. I will come out with a video. So please maximum like and share. And if this we get around 5,000 views, then we'll also make 5 to 10,000 views, also make a video on top 6 topics in obstetrics also. Okay, get in touch with me on phone and WhatsApp. Download the OGGuru app and message me. OBGY will become your most scoring subject, most favorite subject. Just give 4.5 days. You can master the entire OBGY in 4.5 days under my guidance, is my guarantee. So here's wishing you best of luck for all the upcoming examinations, and get in touch with me and share this video with all your friends and colleagues. Best of luck.